So let us go to the next case now by Dr. Sridhar Baddi, percutaneous management of large femoral hematoma with aneurysm. Dr. Sridhar.
Yeah, good evening, everybody. I am Dr. Sridhar, interventional radiologist at Apollo Hospitals, Jubilee Hills. Today, I'll be talking about the percutaneous management of femoral puncture site hematoma with pseudoaneurysm. So, percutaneous access of the vessel into the body is a very important step in performing this endovascular procedures. So the first important step is the femoral access or the vascular access site. So the technique is called Seldinger's technique. Here we do a good palpation of the vessel, see that there is underneath bone support. There is a single, avoid multiple punctures, do a single puncture at an angle of 45 degrees, see that there is good backflow. Once there is good backflow, negotiate the wire very smoothly, then introduce the sheath over it, and if possible, also check with an angiogram so that there are no leaks. So once the procedure is done, before coming out, you can have one more check with an angiogram, then give adequate compression and immobilization of the patients. So these are the most important steps in getting an access into the vascular system. Okay. So now the problem is mostly with the old people and the obese people. In old people, the groin crease compared to the bone and compared with the anatomy of the bone is very lower. So always a fluoro-guided puncture in obese people is important. That will help you in preventing these problems. And in old people, there can be calcification. So see that whenever you do puncture this calcified area, see that you give adequate compression and take extra care in preventing these complications. So intra-procedure also, these can happen due to multiple exchange of the sheaths, the length of the cannulation, introduction of the sheath, various devices during the procedure can also cause these problems. So see that whenever you are doing all these things, be careful and do it very smoothly over the wires. The most common complications include groin hematoma, which is most common and which can easily be detected and taken care of. And when these hematomas, they continue to grow, it may be due to the pseudoaneurysm, that is the vessel wall enlargement will cause this cross dilatation of these blood vessels. When there is a counterpuncture of this artery and the vein, that can lead to AV malformations, AV fistulas, and when these unnoticeably leads extensively, and this can go retrograde, retroperitoneal, and can extend all the way up to the abdomen, pelvis, and also to the thorax. So you should be very careful in preventing this retroperitoneal hemorrhages. So vessel occlusions can also occur due to the femoral clots, which get dislodged and go distally, occluding the leg vessels distally. And small minor branch blood vessels also can get injured. So hematoma is very common, but it can be easily managed with adequate compression and timely intervention and immobilization of these patients. Now, coming to the patient presentation. So this is a typical hematoma where the patient, you can see that there is a groin swelling, tenderness, redness, and bruit and thread can also be seen in pseudoaneurysms. Increasing in size is of concern, and there should be timely intervention in these patients. Now, coming to pseudoaneurysm, how do you diagnose them? So, ultrasound is the most easily accessible modality of diagnosing these pseudoaneurysms. A Doppler scan will tell us that the flow, if there is an abnormal dilatation of the blood vessel in the groin, that's a pseudoaneurysm with the swelling of the blood within it and to and fro of blood within the neck. That will indicate that that's pseudoaneurysm. So, what are the types of pseudoaneurysms? So, depending on the size and the diameter of the neck of the aneurysms, they can be very narrow necked pseudoaneurysms, narrow necked pseudoaneurysms, relatively wide necked, aneurysm. So in very narrow neck aneurysms that can be easily tackled with ultrasound guided probe compression, which will cause the thrombosis of the neck and ultimately the thrombus formation of the pseudoaneurysm itself. So when there is a narrow neck aneurysm, percutaneous ultrasound guided thrombin can be injected, or endovascular approach coil can also be introduced into the pseudoaneurysms. But when this neck is relatively wide, these thrombin and the coils can get slipped away from these pseudoaneurysms. Hence, you may require balloon or stent assisted thrombin or coiling for these neck of size necks. Now, the wide neck pseudoaneurysms are difficult to manage, so they may usually require a surgery or the stent graft placement. So these pseudoaneurysms can also be an acute or chronic. So depending on the day of presentation, they have to be managed. These are the various presentations of the pseudoaneurysms according to the size and the neck you can see. Now, coming to these complications of these pseudoaneurysms. So when they grow abnormally large in size, when they are unnoticed, they can rupture, they can cause infection, they can sometimes ulcer. These chronic, long-standing pseudoaneurysms can also cause ulcers and get thrombosed. And this thrombus or the heart dilatation can cause the compression on the adjacent vein and can also lead to DVT. So, and the patient usually presents with pain, tenderness, swelling, discoloration, bruit, and threads. So here you see the picture showing the ultrasound guided probe compression of the neck. So ultrasound guided probe compression over the neck. So once the neck is thrombosed, the pseudoaneurysm by itself gets thrombosed, and that can be tackled very easily. Now the picture showing here is ultrasound guided thrombin injection indirectly into the pseudoaneurysm percutaneously. So this thrombin is inactive, that is inactive fibrinogen. When it is mixed with thrombin, it forms fibrin and helps in thrombus formation. Ultrasound guided thrombin injection into the pseudoaneurysms. In the second slide, you can see the needle, and in the third slide, you can see the thrombus formation of this pseudoaneurysms. Then the complications in direct percutaneous thrombin injection is that sometimes the thrombin can get discharged distally into the artery and cause occlusion of this arterial system. So hence, care should be taken that adequately the compression is given, and if the neck is wide enough, always do a balloon guided thrombin injection. Here you can see a large pseudoaneurysm on the SA angiogram with a swelling of the blood and the ejection or swelling in the blood and a large pseudoaneurysm. This is basically because of the low puncture in the vessel. Now the next you can see that there is a pseudoaneurysm, though it is the puncture site is well in position, but thing is since this lady being very old, there are calcified vessels, so inadequate compression and early immobilization would have caused this pseudoaneurysm in this patient. Here you see that the first image showing the pseudoaneurysm and the second one showing the post-thrombin injection percutaneous, the exclusion of the pseudoaneurysm. So what are these retroperitoneal bleeds? When these pseudoaneurysms rupture and they bleed, their bleeding can be extensive and catastrophic. So they go unnoticed, patient presents with severe back pain and very fast fall in BP. So these have to be attended and carefully monitored. Sometimes these pseudoaneurysm, the retroperitoneal bleeds can extend all the way to the pelvis, abdomen, and up to the thorax. Here you can see that the blood is seen in the pelvis and perihepatic and perisplenic area. So these have to be carefully monitored. In this slide, you can see that there is bleeding at the femoral puncture site in the first image. And coming to the second image, a balloon is negotiated and placed across the femoral puncture site, across the neck of the lead. And after half an hour balloon inflation, you can see that there is thrombosis of the bleed and no extravasation after that. So to conclude, this femoral access site is, though it is an easy compared to the procedure, but it is very crucial and very important in doing a procedure, because the more than the procedure, sometimes these puncture site access can cause catastrophic complications and land us in trouble. Thank you.
Thank you, Dr. Sridhar. It
Thank
was
you.
nice to have an interventional radiologist telling us all this.
Yeah, thank you so much.
Nowadays, you see, there are more cardiologists than interventional radiologists. So interventional radiologists are more busy than the cardiologists. And therefore, it's difficult to find them, sometimes in a complication also. So it was good to hear from you all the steps which one can do. Most
Thank
important is to buy time till things get into place. One, and we have to see that we don't bleed the patient more. So early recognition is also
Yes.
very important of the complication. And what happens is, normally we do the procedure, happily we go home and we
Yes.
leave it to the staff to remove the sheets. And for them it becomes sometimes difficult. So now couple of just extra points to what I see. This is what I also do in practice, and you may correct me wherever you think I am wrong. So whenever the pulse is not felt in the regular position, do some external rotation of the patient. You know, sometimes it uncovers your pulse, because thick obese patients, there is so much of fat like this. So you do external rotation, then you may feel it better. And then you can palpate behind the bone and get a good landmark also. The other thing is, as soon as we puncture, even though it is anterior, okay, and when you're putting that 035 wire, so what I do is, I take the wire and keep on rotating like this, so that it doesn't catch a branch when it exits out. Otherwise, sometimes what happens is that I see that it catches a branch, goes retrogradely like this.
Yes.
Okay, and then you, because you are so used to not doing fluoro to confirm all this in a hurry, you just take the sheath and try to push it and it's not going. Or sometimes it will go with a slight push, but the sheath has gone and perf, or has gone retrogradely sometimes. So rotating the wire while pushing it in, and if you get the slightest resistance, then you should adjust the needle so that you don't catch a branch or don't get exited. This is some point. And as you rightly said, in long procedures or in complex procedures, bifurcation, left main, or CTOs, 3 hours, 4 hours, where it's going to take more than half an hour, 1 hour, and where we give a lot of heparins to keep the ACT above 350, I always check before I give heparin.
Yes.
Always give a check shoot. No harm, 3,5 cc. Do it on a DSA with a diluted dye. You're not wasting much dye. You're not giving him more toxicity. So I do it on a DSA with 3,5 cc, diluted to 10, give a shoot and see whether you have not punctured either retrogradely or in one of the side branches. See, usually what, I mean, now we are so confident about the coronaries, you forget that femorals also have to be respected. We give a puncture, doesn't come in, withdraw, give another side puncture, get in. But the first puncture has already damaged one of the side branches, the pudendal or superficial, whatever you say, the artery, peroneal artery or something, and then that keeps on oozing. By the time you have half an hour, 1 hour in the procedure, the hematoma is formed, your covers are there above it, you don't see it, and you start seeing the pressures are low or the patient going in vasovagal. You give some fluids, it is better. Again, after some time, it's gone. and I mean, the procedure sometimes gets more complex. You're right. Or sometimes, with that puncture and withdrawal, the blood comes in. When you go deep, it is not there. When you withdraw, it is there. Then you don't know you have punctured the opposite vein, or you have gone from the vein to the
Good.
artery. After removal, you get one aneurysm. So I think you revised the whole thing, and always it is better to, as I said, to remind us that the punctures have to be respected. Thank you very much. Anything else you want to add, Dr. Sridhar?
Yeah, I think that is what you have described. Whatever I've left, also, even if it anything. Thing is, I think there's no harm in checking before we start the procedure, or checking it even before we come out of the procedure. I think that's the best way, especially in obese people and in old people. I think that care can be taken because they are difficult to manage once they land in complications.
So, as I told you, I still emphasize again, after the puncture, sheath is in, no heparin. Take a check shoot. Even if you see the slightest leak, then remove the sheath and give compression. You have still time, you have not given heparin. Wait for 10-15 minutes, no harm in getting delayed further. If it is a big hematoma and you have not given heparin, you still have a chance of giving compression or taking out the patient and postponing the patient. But if you have given heparin, then again to give protamine, all that becomes messy. So the most important thing I have learned is all long procedures, give a check shoot, confirm your puncture is safe, then you can 4 hours, 3 hours on a CTO, and you will see at the end of the procedure also no hematoma, sheaths are fine and looks good. So
Yeah. And one more thing is, I think in obese patients, it's always good to do fluoro guided puncture, because we are
absolutely.
always
Or
end up
else,
doing it
or else I
locally.
tell you, if he's a VIP or something and I feel this, I tell them to do an ultrasound guided puncture. Some people, some interventional radiologists are very good at ultrasound guided puncture in obese patients, such thick and where you have already 8 to 10 centimeters of fat, they give it
Sometimes,
good, and then you are much more confident of that.
yes.
Very good, very good. Nice.
Thank
So
you.
let us
Thank you.
go to the next session. Thank you very much, Dr. Sridhar, for being
Thank
with
you.
us and
Thank you.
giving us this opportunity to listen to you.